Our first talk for the speaker series featured a scholar, our second, a view from philanthropy, and today it is fitting that our third speaker represents the perspective of advocacy. We're fortunate to have it with us today my good friend David Gartner, Policy Director of the Global AIDS Alliance. Global AIDS Alliance is one of the leading advocacy groups in Washington and in the world working on HIV/AIDS in the developing world. David is an experienced hand in D.C., having worked in the Senate as counsel to the Health, Education, Labor, and Pensions Committee before coming to the Global AIDS Alliance. He has broad interests not only in public health, but also education, fate of orphans, and the rights of workers. He is very active not only on U.S. policy on HIV/AIDS, but also multilateral efforts through monitoring of the Global Fund to fight AIDS, TB, and malaria. He's a lawyer by training, a graduate of Yale Law School. He actually started out pursuing an academic career in international relations before he decided to go to the legal and policy route. And I think the world is a better place for it. And I mean that in a good way. I'm delighted David could join us today to talk about his work on HIV/AIDS, but also the role of advocacy in pursuing global public health. So with that, I turn it over to David.
Thanks a lot, Josh. And if I may add an editorial comment, I think an excellent addition to the UT LBJ School faculty, and you should all take his classes. It's a pleasure to be here in Austin. I'm sorry I missed the ski season, but what's really exciting, seriously, is not only in Josh's work, but in the new faculty and leadership you have here at the school. There's a real turn toward the focus on international and a lot of the issues we're going to be talking about today. And I think that's just a really important thing because I know that it's something your generation is really interested about and glad that you all took the time to come here. So as I was preparing for this talk, somebody asked me a tough question. They asked me about my work and the group that I work with, and they asked, what gives non-governmental organizations legitimacy? Or, as they repeated, why do policymakers listen to you? Not a bad question, actually. But what was interesting was that it sparked, for me, a different question, sort of a parallel question. What gives global institutions legitimacy? And why do citizens, or why do nation states, in fact, listen to them? And in fact, I think they're parallel questions because most global institutions currently, like most NGOs, including my own, lack basic democratic accountability. That is, they are neither elected nor are they directly controlled by the citizens of any nation state. Yet I'm going to try and suggest by the end of the talk that the emergence of powerful civil society actors and the development of new, innovative global institutions are actually strengthening democratic accountability in our global system. One important lens, I think, to look at these somewhat theoretical questions is the concrete experience of global health advocacy and the development of institutions to respond to the challenges in global health. So let me turn now to that. AIDS, as most of you know, is one of the biggest challenges of our times. Each year, 3 million people die from AIDS around the world. 3 million people. Another 40 million are infected and living with the virus HIV, which causes AIDS. So that's another 40 million people infected. AIDS right now is most devastating the continent of Africa. Many of you have probably had experience there. I taught there. Well, many children right now are growing up without parents. They're going to schools, but they're going to schools without teachers because teachers are dying faster than they can be replaced in places like Zambia and elsewhere. And many fields are left without farmers. And it's one, not the only, but one of the causes of increasing food insecurity in many parts of Africa. Yet AIDS is not just an African problem. It's also crashing on the shores of the most populous nations on our planet. India will soon take over from South Africa as the country with the single most infections of any in the world. Russia, a part of Europe, is the country with the fastest growing AIDS epidemic of any single country, in the world. China, the biggest on our planet, doesn't yet have a full handle on the scope of infections in their country. But we know that it is a major and a growing problem there. Now, what each of these nations has in common is that they're a nuclear power, they're key to both regional and global stability, And turning back to Africa, what I forgot to mention was that AIDS is also severely weakening the military of those countries, because the military tends to be disproportionately affected, actually, in terms of levels of infection. That, in turn, is having a negative impact on social stability across many parts of the continent. So what we're talking about when we're talking about AIDS is no longer just a public health crisis. It is clearly and fully a global security crisis and needs to be treated as such in terms of the level of priority that gets not just from our government but from governments around the world. Yet amidst this bleak picture, I want to offer you a few reasons for hope. The first is around the cost of the life-saving antiretroviral therapy that exists. In fact, it's existed for about over 10 years now. What's new is that it's now available at prices that make it possible to treat people around the world and not just in rich countries. In fact, today, the cost of ARV therapy, antiretroviral therapy, can be had for as little as 37 cents, much less than you would have paid for your Austin American-Statesman if you read that today. The second reason for hope is that we've moved beyond a period of pioneering pilot programs by the likes of Paul Farmer, who many of you are probably familiar with, his work in Haiti. He's now in Rwanda. We've moved to the level of national scale-up. And I don't just mean scale-up in places like Brazil, middle-income countries that were important pioneers and showed it could be done. I mean scale-up in the poorest countries on the planet. And to go back to Rwanda, Rwanda is actually within reach of universal access to AIDS treatment for those who need it. Not something anyone would have predicted just a few short years ago. The third reason I want to suggest for hope is new institutions have been created to meet these challenges, one of which is the Global Fund to fight AIDS, tuberculosis, and malaria. The Global Fund is now working to finance programs for these three diseases in 136 countries around the world. It's committed already nearly $8 billion. It accounts for 2/3 of all donor funding for both TB and malaria. And it's hard to remember that the Global Fund is only 5 years old. It didn't exist just 5 short years ago. The Global Fund is also innovative in another dimension, not just in terms of its performance-based granting, which is quite important, but in terms of its governance. And I believe these two things are closely tied together. The Global Fund is one of the few global institutions in which developing countries actually have equal representation to donor countries. It's also one in which civil society members from both the North and the South, NGOs, about whose legitimacy we'll return to later, are also on the board, as are people living with the three diseases. In contrast, as many of you know, the governance of the World Bank and the International Monetary Fund are weighted in relation to the dollars provided by donors. So even though recipients might have some role, and that role might be marginally increased soon for the IMF, it's much smaller than for the Global Fund. Civil society is not formally a part of the process at all. They're not part of the governance structure, although civil society can come to meetings. I'll be going to some later in the week. Returning to where we started, you might ask, why should we care? After all, it's the donors' money, and these NGOs, as I've admitted, are not democratically elected anyhow. I would suggest that if we're serious about defeating AIDS and also tackling other major global challenges in the health arena and in other arenas, we need to care about who is at the table, because civil society has been one of the most important catalysts for mobilizing a major response, a response that donor governments clearly would not have done on their own. So if you believe that donor governments can figure everything out and will take action sufficient to meet the challenges on their own, then you probably wouldn't need civil society or donor countries at the table in the way that I'm suggesting they should be. But that's not the case. If you look back to just the year 2000, 2000, by the way, was very far into the AIDS epidemic. As many of you know, there was events marking the 25th anniversary of the recognition of AIDS in the United States, and many people think it's actually existed for a much longer period of time, 75 years possibly, in the context of Africa. But even if you just look at those 25 years, we now look back 5 years ago, so roughly 20 years into the epidemic, the United States was spending about $243 million on international efforts to fight AIDS. Now, while that may seem like a lot of money if we had it, in the context of our global budget, it's a pittance. At the same time, you had 39 pharmaceutical manufacturers suing the South African government to block the use of generic medicines to help people living with AIDS. And our government was actually supporting the industry at that time. 243 million, 20 years into the epidemic, and the blocking cheap drugs for the price of the Austin American-Statesman. Yet today, the United States is spending over $4 billion to fight AIDS globally, a number that is expected to reach $5 billion before this year is out. We're talking about a massive increase and a massive change in our priorities. Low-priced generic drugs are actually now commonplace rather than the exception, and they're used even by the U.S. in its international funding, although there was resistance to that it is now commonplace for first-line drug treatments. We don't yet have generics for second-line drug treatments, and that is a big challenge that we can talk about more later if you'd like. Now, as Texans, you might attribute this change primarily to your former governor. And indeed, he did play an important role. But I want to argue to you that the change in the United States, and in fact in Europe, because there's been big change there as well, represents first and foremost a victory for the forces of civil society around the world. And while I'll be talking more about those in the North, in the rich countries, the reality is that powerful movements in the Global South, including groups like the Treatment Action Coalition in South Africa, were actually the inspiration and the catalyst for groups in the North, including some who'd been focused on AIDS for a long time, like ACT UP, to turn their attention to the global pandemic. So that much of the work that's happened in our own country and in other wealthy countries to change the debate really is a result of solidarity and inspiration by partners in the Global South. Now, together, these activists were instrumental in promoting the generic competition, which had the impact of reducing the prices. And interestingly, one of the people who was important to this was former President Bill Clinton. But he played this role not while he was president, but as a member of civil society in the context of his leadership of the Clinton Foundation and negotiating prices with the generic drug companies. U.S. activists also forged new alliances with faith groups. And that was important because many of these groups had the special attention and ear of the Bush White House. Now, while this process began before, in the context of the debt movement, which is something I know Josh writes about, the deepening engagement of evangelicals with Africa, I believe, has been driven primarily by the issue of AIDS. And it is this left-right axis of AIDS advocacy, from ACT UP, who I mentioned before, to the evangelical community on all sides of the spectrum, but including Samaritan's Purse on the right side of the spectrum, helped to forge a bipartisan congressional coalition that has been at least as important as the President's initiative. It couldn't have happened without it, but the congressional funding has actually moved up much faster and has been much more oriented toward a multilateral response, that is, toward funding for institutions like the Global Fund. Now, global civil society has played an important role as well in other countries. I highlighted some of the change in Europe. In the United Kingdom, for example, in 2005, civil society worked closely with the Blair government there to achieve a commitment to universal AIDS treatment by 2010. This was a commitment which Blair insisted, along with his other G8 leaders, he insisted that each of these leaders, in fact, sign. Now, we still have a ways to go. I'll talk more about that. But the basic point is that the UK government turned into a major ally and then helped lobby other governments to get them to make this commitment to universal treatment. In France in 2006, civil society worked closely with the French government to launch something called UNITAID, a new mechanism to fund AIDS treatment using innovative financing, specifically by taxing airlines, something we do here in this country for Homeland Security, something that France decided was important enough to do for AIDS treatment. It's now in place and it's been endorsed by 26 countries around the world. this year the Germans who are in charge of the G8, and the German chancellor has just recently taken interest in the feminization of AIDS. And this is quite important because whoever hosts the G8, as we saw with Blair back in 2005, has a really big opportunity to leverage other countries. Although Germany's not historically been a leader on this issue, the scale of the global momentum and the work of civil society has played a role in helping to get AIDS high on their agenda in terms of Africa, in addition to other more traditional issues that the G8 worries about, like interest rates and global imbalances and the like. And I'm expecting, we'll see, I could be proven wrong, but that we will see some major new commitments emerge in June when the G8 meets in Germany. So returning to where we started, I want to just offer a few brief thoughts about the legitimacy of NGOs in the global arena and about global institutions. Now, I believe that the legitimacy of NGOs comes not from democratic accountability, because it is true, there aren't elections. I mean, they're boards, but they're not elections. And while it's linked to solidarity with allies in the South, like Treatment Action Coalition, and because those in the North, for example, have more voice often in terms of rich governments, I think it actually, I would put it on something else. I think it's linked to the universalistic nature of the claims put forward by NGOs and civil society. In the case of AIDS, it was the idea that we should try to provide affordable life-saving medicine and treatment to those who would die without it, was such a powerful claim that it resonated on both the left and the right. It resonated here in America and elsewhere around the world. It's a claim that originated with the Treatment Action Coalition, but I think it was as much the power of the claim as it was those who were making it that made it so forceful. Now, when NGOs turn to more parochial claims, as often they do, or indeed try to build their own empires, as sadly too often they do, then I think they lose a great source of their legitimacy in this global arena. Now, looking at global institutions, I think that their legitimacy is linked to a couple of different things. First, I think it's to their effectiveness in solving global collective action problems and responding to global challenges. We wouldn't need institutions like the Global Fund if we didn't have a crisis like AIDS, or if nation states by themselves could solve it, or had shown themselves willing and capable to solve it. But they haven't, and we do need it. And this is going to be the case across other issues, whether your interest is the environment, whether your interest is peace and security. I would suggest that there's similar needs in these arenas as well. But I think when you're looking at global institutions, you need to also look closely at their governance structure. But it's not simply from an idea of democratic accountability, because then you'd want elections. And I'm not against elections for these global institutions, but that's a big undertaking in a world as big as ours. What I think is important in terms of the governance of these institutions is that you have equal voice given to developing countries, something that is increasingly true in these new institutions, but really is not true in the most powerful ones we have. And that you give a role to civil society. But my argument for giving a role to civil society is actually more instrumental than anything else. It's because these institutions so easily lose their boldness and sense of urgency and focus on their mission because of the demands of day-to-day life. Day-to-day bureaucratic demands undermine the mission and urgency that existed at the root, not just of the Global Fund, but indeed at the root of the founding of the IMF some 60-plus years ago, and the World Bank some 60-plus years ago. But as a rule, the reality is that donors don't tend to make commitments that will require them to spend more of their citizens' money without a push. The Global Fund would not even exist without the push of the claims put forward by civil society. The Global Fund would not have achieved the success it has but for the resource mobilization of civil society, which frankly was linked to the sense of investment and commitment to this institution of which they were on the inside of, not just shouting at from the outside. So while we still have a very long way to go to reach that G8 commitment that I mentioned, universal AIDS access, and we don't have a lot of time to do it because the commitment was by 2010, I do think we now have a chance to be remembered, and you, in fact, have a chance to be remembered, as a generation that did much more than look away, as tens of millions of our fellow humans on this planet died for lack of a 37-cent pill. So I just want to thank you for taking the time out of your day to come and listen. I want to encourage those of you who were moved by this issue to look for outlets, and I'm happy to talk more with you about that in questions. And I want those of you who are interested in this more from a theoretical perspective to consider the lessons of global health and the role of civil society and the importance of having real new and different voices at the table of these global institutions in your thinking and your work about other kinds of global challenges and other kinds of global institutions. So with that, let me stop. I look forward to, hopefully, a lot of questions and some challenges, too, because I like that, too. Thanks.
Yes. Hi, my name's Michelle. I'm going to start out with a challenge, if that's okay.
Yes, it's very.
You really focused a lot on ARVs, and I know that's the popular thing to focus on these days.
Yeah.
But as someone who worked with HIV in Africa for 3 years, Zambia, actually, you mentioned
Great.
Zambia.
Great.
I would argue that the better place to focus our efforts would be in prevention, because after all, universal access to ARVs is just going to mean a huge population of infected people who are living a healthy life, but with the disease, and even with ARVs, the disease can still be passed on. So you didn't really touch on prevention at all. It was all about ARVs. Do you want to address that at all?
Yes, I do. Thank you. And first, you're absolutely right. There is no way with treatment alone we're going to get ahead of this thing. The reason I focused on treatment is because in the story I was trying to tell about how things have moved on the funding side in the last, few years, I believe that treatment has been the motive force, not prevention. But in terms of solving the problem, you are absolutely right. Prevention is, at least some would say, even more important. The thing I would take issue with you is that treatment has no impact on prevention. In fact, people were not going to get tested in nearly the volume that they are now until they knew that there was some hope. In fact, people who are on ARVs have their viral loads reduced to levels at which the research has shown there's a very low rate of transfer to your partner. So I actually believe that treatment is important to prevention, and so I would argue with you on that. Turning to the broader questions of prevention, let me start from not such happy news in terms of the U.S. initiative. While I think it has been path-breaking on the treatment side and really shown that we can go to scale in Rwanda and indeed in Zambia, there is, as many of you know, an earmark that's attached to it around abstinence. And that, unfortunately, has distorted the prevention response, not only by our country, but I believe in these countries by more generally. And that's of great concern to me. The concern that I have is not that abstinence is not an important part of the response. In fact, it is. Along with faithfulness, along with condoms, along with other things that people don't talk about, things like basic education. Kids who go, for example, data out of Uganda, kids who make it through basic education have half the rate of infection of kids who don't have formal schooling. If they make it through secondary education, they have 1/4 of the rate of infection. So even putting aside the ABC fight, which is an important set of questions, you just get kids in school, you can have enormous impact. And it's interesting because I highlighted that Uganda was where this data is from. That's one of the countries where people are pointing to no, it was A, no, it was C. Well, don't forget the E for education. Another thing that is untouched so far by our AIDS initiative on prevention is violence against women. The reality that we're finding is that even in places where there's been relatively good comprehensive prevention, until you deal with violence against women, and particularly sexual violence, you're not going to get to the last sort of set of infections that are quite important. So, more broadly, things that you can do to empower women, to change men's behavior are quite powerful. So let me just return for a second to the ABC that I mentioned. The concern that I have about this earmark is it takes an a la carte approach. And we can't take an a la carte approach to AIDS prevention. In other words, it suggests that just do the A, and then maybe for some people, high-risk individuals, you can just do the C. I think you need to integrate these approaches. And more importantly, most public health experts and research suggest you need to integrate these approaches. So my concern is not just that it's distorting it because it's putting too much spending on one piece of the equation, although it is. It's also that it's separating out things that should be linked together. And then my third concern is that it's leaving out altogether education, violence, and other important things that would help on the prevention side. So thank you for that important challenge. Yes?
You mentioned earlier that there was some good left-right cooperation between like evangelicals working in Africa and in the U.S. What's the relationship between kind of the global AIDS civil society groups and the Catholic Church?
Yeah, good question. The Catholic Church was also helpful. The Catholic Church was actually more important, I would argue, in the debt movement, which was much clearer, much more closely linked to their efforts. But the Catholic Church has been an ally as well, both at the national levels and in local levels. I'll give you some concrete examples. At the national levels, in the run-up to the Bush announcement, we also got key Catholic bishops, Archbishop Washington and others, to reach out. So they were important. They also have not always agreed with the view that I just put out on prevention. So that's similarly been a challenge. At the local level, it's been also interesting because, for example, one of the reasons there's been real progress in this isn't because of what happens in Washington. It's actually as much because of what happens out in the country. I mean, for example, in terms of this jump in congressional funding levels, the first stage of how they spend your tax dollars is that they put together a budget. This is something that's happening right now. And the budget basically parcels out into big pots. The big pot related to foreign assistance being something called the 150 account. Well, a couple of years ago, Jim Nussle from Iowa was the head of that budget committee. And so he didn't listen to President Bush's request for the 150 account in order to create the possibility for more spending on AIDS, and he cut it by billions of dollars to give to other things. The Catholic bishop in Iowa, in his eastern Iowa, along with a Lutheran bishop there, were very active, reached out to him. In fact, in the case of the Lutheran bishop, spoke to the press. This was enormously powerful. And in fact, Congressman Nussle subsequently said, yeah, this is why I changed and increased the funding. So the Catholic Church, like these other faith groups, have been important not just at the national level and with the Bush White House, but as important at the local level. And the reality of our system, which is unique, it's not like this in France, let me assure you, is that those who control how your tax money gets spent are local elected officials. So citizens anywhere can actually have a really powerful and important impact on the priorities of our country. And that is one of the, also I talked less about, but one of the other lessons, I think, from the AIDS movement. Yes?
You mentioned briefly the publicization of AIDS and the Germans were getting involved in that, and I hope to study that. And I was just curious your thoughts in regards to prenatal care and AIDS and just really targeting women with children, because I have trouble with the prevention argument. I think there are a lot of issues, and I don't really think it's quite working, but I think if maybe you can target the mom who's most likely going to transmit it to her baby and stop it there. And I was just curious as to your thoughts about it.
Yeah. Well, one of the things that most people don't know is how in this sort of, I think, partial success story of scaling up AIDS treatment, how little we've done for the kids on pediatric treatment. And that is a real disgrace and something that's starting to change now. And the kids, as you're pointing out, get it mostly from their mother, during childbirth, during breastfeeding. And yet, I was suggesting a 37-cent pill a day. In the case of preventing mother-to-child transmission, or PMTC, that would cost you just a few dollars, period. And yet, it has not been introduced in a widespread, systematic way that it needs to. So, I agree with you that that's a big part of the problem, and I left that out of my prevention discussion. What I don't think I agree with, if I understand the gist of your question right, is that alone would make such a big dent on the prevention problem. The reality is that while that's the main way that children get it, adults are getting AIDS through all sorts of other ways, through sex, through needles, through blood transfusions, And we have to tackle each and every one of those problems. And I haven't even talked at all about sort of the challenges of needles and blood supply.
I just meant that I think because abstinence and certain beliefs are so ingrained in specific cultures, I think that there's just a lot of really big barriers, and obviously there's so many other problems with prevention, but I think it's just one way to kind of tackle one of these problems, and the barriers just might not be quite as high.
Well, and in fact, that was one of the, it's interesting you say that. That was one of the ways in which some on the more conservative side of the spectrum, Jesse Helms, for example, got engaged in this issue. So I agree with you that it's like a good way to introduce people to the issue, but let me just push that argument a little farther with the reality that it is actually married women who are at greatest risk in Africa. It's not unmarried women. It's we have this vision of this is linked to promiscuity. Well, it's married women, often young married women, who marry older men who are actually at greater risk than unmarried women. So marriage is a risk factor for HIV and AIDS. These are women oftentimes who were abstinent until marriage. These are women oftentimes, almost always, who are faithful. Their husbands not always as faithful, but they don't control that. So what option are we leaving these married women if we don't open up ourselves and encourage, in fact, other cultures to open up themselves to embrace a broader range of prevention strategies? So I'll leave you with that thought. Yes?
Some people say that the lack of medical infrastructure is a major problem with delivering ARVs.
Yes.
Is that argument overblown, or is it really a serious issue that needs to be addressed?
It is a very serious issue. It is a serious issue, though, not only with respect to ARVs. What's really happening is that there has not been this kind of massive investment in health in Africa and other poor countries ever. The last major undertaking I would point to would be the child survival or the inoculation efforts. But those, frankly, were much more targeted things. You give somebody a smallpox shot, and they haven't all been carried through in the way that they need to, and that we can talk more about that. But what's being revealed through AIDS treatment is that there is not the level of health infrastructure it needs to be. Part of the reason for that actually goes back to some of these other global institutions that I mentioned. The IMF specifically has wage ceilings, and these wage ceilings limit the amount of public sector workers that can be hired. So, in fact, one of the reasons that there's not a strong health infrastructure in Africa is because IMF constraints have led them to get rid of, lay off, fire, whatever word you want to use, health workers, and are now limiting their ability to hire new ones. I met with the IMF rep in Kenya, because there's a national representative in each country, and they're actually trying to do something interesting. They're trying to create an explicit exception for health and education. In other words, these are such vital things, and there's money flowing actually from donors, so there's the money to do it, to create an exception to these wage ceilings so that they could scale up. And this is something some members of Congress have taken interest in, but this, I believe, is one of the most important issues. But it's only one of the solutions to the crisis you're highlighting, and it's a big focus, in fact, of many activists now, and it's a big focus of the German G8. And one of the things I'm advocating in the context of this upcoming G8, we'll see if it comes to pass, is that we need a health coordination mechanism, not a new financing mechanism. The Global Fund is doing great work on the financing side. Unfortunately, some of the donors didn't want it to finance health infrastructure, so it's part of why we've got this problem. But what we need is, because we have countries going in there and doing their own individual efforts, we need actually a one table where even all the donors sit together. I was emphasizing bringing new people to the table, but even they don't all sit together in terms of coordinating their efforts. And that these efforts should be linked to national health strategies. We're encouraging countries to develop AIDS strategies. That's important, but they should be embedded within broader health strategies. So this is another gap, I think, in the global governance system that we now have. Yes?
I've kind of had, not even just in health, but overall kind of issues with the lack of coordination between lots of different actors. And do you feel like that's hurt the kind of push, or what kind of effect overall do you think it's had?
Yeah, I think it's definitely hurt. And in the early years of PEPFAR, which is the U.S. AIDS initiative, I believe that the focus on kind of go it alone approach hurt as well. And the good news is there is now much better coordination between PEPFAR and the Global Fund. With new leadership at the Global Fund, new leadership at WHO, I think there's going to be much better coordination across all these agencies in terms of the AIDS response. So major issue, did cause us problems. I think moving in the right direction. Yes?
You talked about the increased funding for HIV/AIDS by the U.S. government and also internationally. But two issues that I see in the funding for AIDS. One is that a lot of it goes through non-profit organizations or NGOs which are working internationally. But there is very little evaluation of those interventions. And the evaluations are mostly limited to visit counts rather than outcomes.
Yeah.
So for the PEPFAR, for instance, the USAID would be hesitant to do an outcome-based evaluation. They would rather just tell that we have seen so many people or held so many conferences. And therefore the learning that could have happened in the last few years or last 20 years in fighting AIDS does not seem to be reflected in the interventions that have been made. So for instance, on the issue of prevention, you just mentioned, and I would disagree a little about how you presented it, because there was a common ground statement that was published in Lancet in 2004, signed by 140 experts, which actually said that the policy to fight AIDS would be different for different populations, and also depending on the nature of the epidemic. It can be a localized epidemic, or it can be a generalized epidemic, depending on the country and what you need to do for that. And also for different age groups, the public health intervention would be different. And it seems like that is not reflected in the interventions that are made year after year. We are almost doing the same things. There's a lot of focus on treatment and not enough, and a lot of lip service to prevention, but not enough, effective preventive policies at the national level in many of these countries. And in fact, the UN AIDS report of 2006 clearly states that the only countries where at a population level you have reduced HIV/AIDS is countries that have had a good HIV prevention policy, whether it was Uganda or Thailand or Guinea or whatever. And the second aspect is that a lot of the funds that are allocated to fight AIDS in sub-Saharan Africa, going through large multinational NGOs, actually end up in the pockets of top executives and the NGOs headquarters themselves. So if you look at the money that is effectively reaches the worker in the village in Zambia or Uganda, or the amount that goes to supporting the orphan in a certain village, it's really a minute fraction of the allocation that is made at the international level or at the US level. So how do NGOs that really want to make an impact work this out through their own system, especially when that system is not democratic itself?
Well, you're raising a number of important points. Let me try and respond to at least two of them. One is about evaluation, and one about where does the money actually go and how much gets out of the Beltway. On the first of evaluation, this is a major problem. There's no question. It is something on which there's been some improvement, and part of that has actually been a result of advocacy. Let me give you a concrete example. Orphans, you mentioned. One of the things we were very involved in was making sure that this AIDS initiative took into account orphans, and got Congress to say that 10% of all the money needs to go to orphans. But the way the administration was initially counting that, like how they were helping orphans, was basically any orphan they encountered on the road. Now, we pushed back, others pushed back, and now they actually have, I think, a relatively sophisticated approach, which is they've identified a package of 6 essential services, and only if you have, I think, 3 or 4 of these essential services do they consider that an orphan who is receiving the package. So, it's another example of the interactive effect between, those who are trying to administer these programs and advocates on the outside. But there's still a long way to go, and I'd give you an example there on the education side, which is, we, in terms of U.S. spending on education, can't yet account for how many kids we're helping to get in school, and these are criteria that we and others are advocating really need to be at the forefront to make sure that you're having some impact. And it actually links to your next set of questions. Because if we had those benchmarks, right, that you needed to get X many kids in school, let's say, then NGOs that are receiving this money would be held accountable to precisely those benchmarks. Part of the problem of NGO accountability, and this is a specific kind of NGO accountability, programmatic NGOs. I should clarify that my group actually is an advocacy group. We don't do any programs on the ground. But those that receive U.S. government money and do programs aren't held accountable to broader targets usually. One of the actual advances of PEPFAR is that it did hold them to some clear targets around treatment, around prevention, and around care. That said, there is still too much money that doesn't get out of the Beltway. And the reason for that is because it goes through U.S. NGOs, some of the big and famous ones you know about, and it pays for lots of things, and enough of it doesn't get to where it needs to. The solution to that problem, in my view, is twofold. One is we need to give more support to multilateral institutions like the Global Fund. That's precisely the reason why our organization is saying give the money there. Not only is there less overhead, but it leverages money because every dollar we give, $2 have to come in from the rest of the world, most of the Europeans. So that's one reason we're big advocates for the Global Fund. The other solution is, I think, a more far-reaching one, but a no less important one, which is we need to move beyond the current model and structure of USAID. The project model, the fund NGOs here that ultimately do a project there model. Now, the UK, the United Kingdom, did that not so long ago. When Blair came into power, they reorganized their foreign assistance and created something called DFID. That's and what they do is they work directly with governments. Now, they don't give money to just any government. They give money to governments that actually can show that they have some effectiveness in these arenas. And I think, and they're also very poverty-focused, because the other thing that you didn't highlight that's going on right now is there is a reorganization of our foreign assistance, but it's moving more towards short-term foreign policy goals and away from some of these longer-term poverty-focused development goals. So I would suggest that what we need is a structure more like the UK's DFID. And at least one of the presidential candidates has already suggested this. I'm hoping, and we may see others suggest this, because until we move to a truly different model for how we do our foreign assistance, then it's my view that we should be doing as much as we can through multilateral mechanisms. So as much as possible gets to the ground. Yes.
Thank you very much. I learned a lot from this. First off, I am an academic, so I'm tricky, so I'm starting with the correction.
Sure.
It's the Treatment Action Campaign, not the Treatment Action Coalition.
I'm sorry. I wrote campaign, but if I said coalition, I apologize.
Okay. And then I'm wondering if you could sort of speculate a little bit about the connection between the debt crisis and the HIV/AIDS crisis in sub-Saharan Africa. Because part of me is anxious that looking to NGOs is a way of letting weak states off the hook, and those states are weak because so much of their GNP is going towards debt service. So I'm just wondering if, at a macroeconomic or political level, what you think about the relationship between the HIV/AIDS crisis in sub-Saharan Africa and the debt crisis. And then the second question is thinking about NGOs and public discussions of sexuality. Because in the part of the world that I work in, we've had an AIDS denialist president for a while, and he backflips. And it's actually very difficult to actually have a public discussion around the fact that this is a sexually transmitted disease without invoking the legacies of colonialism, without invoking stereotypes of black people as lascivious savages. That actually there's a range of sort of cultural, historical forces that stand in the way of actually kind of rational prevention or treatment programs. So I'm wondering if, how, do you think that's something that structures of global governance can intervene in, or is that something that's just going to have to be worked out locally?
Yeah. So, and remind me, the first question again was debt. Yes. Okay. Let me start with debt. There's no doubt that there's an important link between the indebtedness of these countries and the lack of any health infrastructure and the failure to respond to AIDS and other diseases. It is also true that the debt relief that's come about has been helpful. You can point to some concrete examples. Uganda used it more for education, actually, to eliminate school fees and get kids in school, which probably had an indirect benefit on AIDS. The recent round of debt relief, which was more expansive, this is another thing that came out of the 2005 Gleneagles G8 that I didn't mention, is actually much deeper and hopefully will be used for some of these ends. But I have to be honest with you, I'm not sure that it will. And let me tell you why. We in the United States, when you think about our priorities, how we spend our money domestically, if there's a choice between roads, health, and education, who gets the money? Roads, every single time. We in the United States have a different way of delivering foreign assistance that I didn't mention called the MCA, the Millennium Challenge Account. And it purports to leave it up to the country as to what they want. Now, there's been some imperfection in how that's been done. But you know what countries keep coming back with? Roads. So I have to be candid with you and say, in and of itself, I'm not convinced that governments in Africa or anywhere else are going to act differently than our government acts and will privilege health and education by themselves. What we've seen, actually, is education's done better, partly because it's been seen more of a winning political issue. For example, Kibaki in Kenya eliminating school fees, Mkapa and others. Health has not seemed to have that resonance. That said, I do think there are specific other things you could do to link debt and health. We have been involved in the idea of like debt for health swaps, something specifically called global fund debt conversion. And it looks like that will go forward, at least in one country, and hopefully could be a model for others. So that specifically debt would be different kinds of debt, because the G8 debt deal didn't deal with all kinds of bilateral debt, between one country and another. It dealt with multilateral debt. But that you could use some of this bilateral debt, cancel it in exchange for scale-up of TB programs or AIDS programs. And I think you'll see some of that happen this year. And your next question was about the dialogue around prevention and whether global institutions can foster that. I mean, they can foster it, I think, in the sense that they can finance it, right? They can finance programs on the ground. Can they actually change the debate and the tenor of debate in a country, which I think is the gist of your question? Probably not. I mean, this is where there's also an important role for leadership and national level leadership, which is not something I talked about. And Becky would be an example of exactly what you don't want. And there's some other examples of what you do want. One thing I left out, though, that connects a bit to your cultural concern that people perceive, again, it's back to promiscuity. Is that really why Southern Africa has more infections than West Africa or other parts of Africa? And what's interesting is the recent...
That's because Southern Africa has more roads.
Well, it could be because they have more roads. No, and in fact, sadly, AIDS spread across that's a good point. No, I was going to highlight something else, which is Southern Africa has less circumcision. One of the really provocative, and I'm sorry I forgot to mention this, findings is that circumcision, male circumcision that is, can reduce the chances of HIV infection by as much as half. I mean, I'm sorry?
No, I don't know if that's been completely confirmed yet.
Well, the WHO has just recommended it based on several studies that have been done. But do you want to add something?
No, some work that I'm doing in rural Malawi where we're coming up with a lot of discrepancies that would prove evidence to the contrary. The most infected region of Malawi that we work in is Malacca, where there's a heavy Muslim population and circumcision is highest. It's the highest prevalent region,
there.
Yeah.
Okay.
So
you're challenging not that circumcision, you're challenging both that circumcision can work and whether that accounts for any of these differences. Okay. Well, I haven't yet seen your research. I'd be interested in seeing your research. Until I do, I'm going to rely on the WHO and the research that I have seen. And I think it's a potentially powerful intervention. It may be overstated. It also, and this could relate to why you're finding dissonant things, it also is going to relate a lot to how they do it. Because once you circumcise someone, they need to abstain. I mean, abstinence can be powerful throughout, but they really need to abstain during that period because they are very, it's a sore. So I don't know how they're doing it in Malawi versus other countries, whether that might account for part of this discrepancy, but I'd be really interested in seeing your research in any case. So, yeah. Yes?
I have two
questions. We talk about prevention, treatment, and I want to know if there are any programs like for orphans.
Mhm.
We talk about orphans, and
Yeah.
how are you responding to that, like without parents, without teachers, and how are you approaching that? And also the person that asked the question before, like how you're tailoring programs more like to local regions. And you were talking how like donors should sit together and in big programs according to
Mhm.
national health systems and programs. But I also wondered if you're learning from experiences like of medical anthropology, you mentioned cohort
Mhm.
and innovations that have been done like on that side. How are you learning from that to really respond to the specific?
Well, speaking of accountability, he's on our board, so I hope we're learning that. But no, to answer your broader question about orphans, we have actually been very involved. I think I mentioned that we help to ensure that 10% of all the money goes to orphans. We then, I sort of played a big role in drafting legislation that passed a couple years ago to kind of define what should the orphan response look like, and it includes a range of things. One of the biggest is education, because if you look at mothers who are about to die, one of the biggest concerns is not just who's going to take care of my child, but who's going to pay for my child to go to school. So if you can get rid of these school fees again that I highlighted earlier, that's an enormous improvement for orphans. And then you also need some targeted interventions because they may not have the shoes to go to school and other kinds of things. It also is basic care. Obviously, community care is what we've advocated as opposed to orphanages. Then you get into issues of like food security. So it really is, that's why I mentioned this package of services across a range of areas. Now, the good news is because of this 10% earmark, we're going to, it's moved from there was a $15 million initiative before all of this for orphans, and we're now in the hundreds of millions. I think it will be approaching 300 million plus this year. That's good news, but it's not nearly enough in terms of the scale of what we need. And actually, one thing we are actively working on right now is to try to get a new initiative around orphans and education. So it's another thing I'm hoping we'll have to celebrate soon, but we'll see. So. Yes?
I was wondering if you could talk a little bit about the Rwanda example. What are the specificities really of what they're doing, and what can we learn in general? Because, of course, Rwanda is a lot of people in a very small area.
Yeah.
And so I just wonder, is the lesson, if you try hard enough and spend enough money, you can reach a lot of people, or if we're learning more from the Rwanda program?
Yeah. I want to first say I'm not an expert on Rwanda. I was highlighting that because we're closer, but I'll give you my thoughts. I think it certainly helps that it's a densely populated small country, no question. So, in that sense, maybe it won't apply to Nigeria, right? However, I think there are a couple of things they're doing right. One is this issue that you highlighted of national leadership. What's really interesting is our AIDS initiative, PEPFAR, is being implemented very differently in different countries. For example, I was in Kenya where, basically the U.S. has bypassed the government, In the long run, I think that's not a good thing, but that's been their approach to quickly scale up things. In Rwanda, the health minister said, you're going to work through me. So it's very integrated through the government's own efforts, and I think that's a big part of the success, and it has support at the highest levels from Kagame and others. It also has a lot of resources going into it. Paul Farmer's moved there, the Clinton Initiative is there, Jeff Sachs has Millennium Villages there. There a lot of attention, I think rightly so, has gone there. And I guess the last thing is I think maybe there's a more general lesson that this is possible. That the Global Fund is working there. PEPFAR is working there. They're coordinating, that this coordination, to go back to your question, and that these new mechanisms and initiatives really are working, and that you can see this impact to scale best in a more densely populated, smaller place. So that would be my thoughts. Yeah. Yes?
I've been reading a bit on just funding in general. Is this just, how much money would be needed if you could wave your magic wand and say, if you could give me, X amount of dollars? Because I've read some figures this was a New York Times article a while ago, and the guy was arguing that, maybe it's maybe it's not a money issue after all. Maybe it's just been a governance issue, like you said. Or
Who was the guy? Do you remember? Was it Bill Easterly or?
It was referencing an article about philanthropy in New York Times Magazine.
Yeah.
A chart on the front of it. And he was just laying out, like, you know, the American state at 10% higher level, we could tackle all these issues. And it got me really to thinking about the issues he was raising about, would that really solve it? You know, is it an issue of money at this point? Like, you know, if the U.S. was just up there giving to X level, could we actually tackle this thing in 20 years?
I think it is about money, but I don't think it's only about money. Those who tell you you can do this without money, I think are lying to you. You know, I highlighted, you know, one of the people who's making that argument. Those who say just more money will do it are also lying to you. The reality is you need effective, I mean, Rwanda is an example of a place where the money is moving and working. On education, interestingly, I'd point you to Kenya, which is not a place that most people think of as where money works. But what the government there did is they set up bank accounts for each school. And so money goes from the finance ministry direct to the school, and there's school committees that have to be accountable and publicly show on the blackboard how they're spending that money. You know, you need money being spent in ways that gets to those who need it, to go back to the question of, you know, the structure of our government. So I wanted to get beyond the Beltway first, and then I wanted to get in the hands, you know, get to the school level in Kenya. So those are the kind of intermediate challenges. I think more money for health alone probably won't do it also. And I say that because, you know, to go back to my prevention discussion, education, unless we're investing, you know, in a serious education, universal education response, then we're not going to have the impacts that we could have had on health. Unless we're investing in a serious way on an anti-violence initiative, which might include microfinance for women, because we found that when microfinance is paired with programs to educate women about violence, that it's much more effective. You know, unless we're actually intervening on a multiple number of fronts, then I again think we won't get all the value. So yes, we absolutely need more money, but we need it to be, you know, to be programmed in an efficient and effective way, and to be used towards a multiplicity of goals around the same problem. Does that answer your question? Okay. Yeah.
So I wanted to ask two questions, sort of a follow-up with Steve's question about the possibilities for large-scale donor-supported for health systems, because there's sort of a deep skepticism from Easterly and others that maybe we're just not smart enough to know how to do that. It's not just about public health, but broader issues of governance in developing countries, that we just can't get the incentives right on our end, and we don't really know. And then there are people like Alex DeWalt who really worry that, you know, what we'll end up doing is some sort of quasi-neo-imperial project that takes on governance in developing countries, that does that sort of goes around the state as donors have done to a certain extent in Kenya and other places, and you end up you know, undermining the ability for countries to be able to provide for their own needs in the long run. So there's that question on the skeptical side. Then there's the other question about the long-run political support for public health. Let's say we can resolve that issue and we're satisfied that, you know, either large-scale or increases or at least sustained attention on the order that we've had are a good idea. What do you see the future of political support for public health, global public health, both here in the U.S. and abroad in the years to come?
I mean, in a way, you're asking two different sustainability questions, right? I mean, one is about, are the systems going to be sustainable, or can we help them to be sustainable in these countries to take it on? And the other is, will the, you know, this political constituency that I talked about be sustainable to keep the financing on? Is that right? Okay. You know, they're both hard questions. I actually feel somewhat optimistic on the second, so let me hold that. I think that's in some ways not an easier one, but one I'm more hopeful about. On the first, you know, one of the real weaknesses of PEPFAR as a model, the USAID's initiative, is that it was not focused around building long-term health infrastructure. It instead was focused on delivering short-term results. Now, importantly, these are results for precisely the thing that I was advocating here today, you know, life-saving treatment for millions of people. So, you know, that makes it harder to argue with, but I think that the model that they used in Rwanda, where they did that in partnership with the health ministry, or even sometimes at the direction of the health ministry, is a much more sustainable model than what we saw in Kenya, where they basically bypassed government officials. So I worry that what we've done so far isn't helping on the sustainability question. I also worry that the donors made a decision that we and other groups fought, that the Global Fund shouldn't have a health system window, because the Global Fund could now be a major financing mechanism for strengthening health systems in these countries, but it's not. So I think on both are examples of where donors have been short-sighted in terms of the goal of trying to create sustainable health infrastructure. The harder question is, okay, now that we're here, what would it take to actually do it, or is it even possible? I've given one example of a coordination mechanism. Obviously, much more needs to be done also at the country level, these IMF caps being one piece of the puzzle. I think those two things alone could have a major impact, actually. But it's a major challenge, and I don't want to pretend otherwise. On the political question, I guess I'm more hopeful. If you talk to me a few months back, I might have been less hopeful, because some of you may know this, but when the Democrats took over the Congress, one of their first moves was to say, we're going to flatline spending. We're going to have a CR. It's a technical term for a continuing resolution, but it basically means we're going to level fund everything. Well, that may be fine and well with some things, but we and others had gotten a $1 billion increase in terms of the AIDS funding. So basically, the Democrats took control of Congress, and one of their first decisions was to cut $1 billion out of global AIDS funding. Well, that got me worried. And in fact, we and a lot of other groups put enormous amounts of pressure on the leadership, and luckily had some strong allies in the Congress as well. And they restored that, and in fact restored it and did a historic contribution to the Global Fund of $723 million. But that was not a given. So if you'd asked me a few months ago, I would have said, maybe Democrats are going to say this is a Bush thing, therefore why should we support it, beyond when when we're in charge. And thankfully that didn't happen this time. Now that's not a guarantee or assurance that the next president, for example, wouldn't take a similar attitude and say, well, global AIDS was the last president, I'm going to focus on maybe global education, which would be a good thing, or maybe something else. That said, I've been really impressed with the strength of this bipartisan coalition. Now, admittedly, like many things in life, it's fragile. It depends on individuals. Dick Durbin is one of our greatest champions. I think he'll be in the Senate for a while. Actually, Rick Santorum was another important champion. He got knocked out of the Senate. So one of the challenges is to find, the person on the other side of the aisle, and we're working on that. So it's fragile in terms of it being based on individuals, but at the same time, it's deep in terms of the resonance. Because when we, for example, if you were to push the Congress on any other foreign assistance issue, short of those that are really tied to powerful interest groups, but in other words, a universalistic claim, it doesn't work. If you argue for more funding for foreign assistance overall, as some groups are trying to do, it fails time after time. Whereas the specific claim that I talked about in my talk about universal AIDS treatment has a certain resonance where people feel that they can't be against it. It may not be their top priority, but they're not going to actively say this is a bad idea. What they will do sometimes is not give it the attention it deserves. So I think it will be a fight, but I am optimistic on the political sustainability side, at least in the medium term. The other, I think, is actually an even harder question, in terms of the health structure and sustainability. Yes?
So just to add on to what you're talking about, in terms of politics, which presidential candidate do you think would make the biggest difference in this area?
That's a good question, and a hard question. Well, last time around, there are a number of us, in the wake of Bush's announcement, helped to convince all the Democratic candidates to commit to $30 billion for global AIDS, so doubling. And it ended up being the biggest single number in John Kerry's book, his policy book. But he didn't become president, so that's not really that important. I think it will be probably even harder to get this set of candidates on either the Democrat or the Republican side to get to those kinds of numbers. But the good news is there are lots more people who are working and thinking about this. There's lots of advocacy groups that are engaged in it. The one, in terms of the presidential campaign itself, the one candidate who's so far come out with something in the context of the campaign is John Edwards, and it actually focuses on universal education. That's also a big issue for Hillary Clinton. She has a bill, legislation that she introduced last session, and I think will soon introduce again this session, around universal education. And it's an issue that, to stay for a second on the Democratic side, that Obama has also talked about a lot. In fact, he went to California not so long ago and talked about an extra $1 billion for AIDS funding. So I think, and let me just focus, at least for the Democrats, only on the first tier. So I think all of them would be supportive. I think the real question you have to ask, as you're trying to figure that out, is who is so passionate that they're going to keep this at the top of the agenda, and who is going to take on the question of how the money gets spent. So, I would encourage you, with the Democrats, to look at their platforms as they develop. On the Republican side, it's interesting because the one strong ally, well, no, there have been two allies, but in different ways. John McCain has been a strong ally on the generics issue. He was very instrumental in working with us and others to push the administration to use generics, and that helped. He has been less of an ally on funding issues. So, I think sort of don't know where that'll go on the funding side. Someone who's been a big issue on funding is Sam Brownback. Although he's not one of the top tier on the Republican sides, he's been the most outspoken on that side on these issues. However, we've not agreed with him a lot, or almost always, on prevention. So, you've got people who are good on one issue, not good on another issue. You've got people who, have been good in the past, but will they be leaders on this in the future? I mean, that's what I would be looking for. Will they commit to specific large numbers? Will they commit to, innovative deliveries of this, whether using global, multilateral, or changing how we do business in terms of our bilateral assistance to focus on poverty? So those would be the questions I'd be asking. We've still got a ways to go.
I think we do, as long as people want to ask questions.
Just from a larger picture, again, goes back to a comment that somebody had made. Is it possible that we are just tackling this problem in a fundamentally, faulty way? Because it seems like that as you add other factors that might affect the epidemic, so you just talked about education,
right,
and then we talk about governance, and then you can also talk about security as having an influence on the behavior of the people. But fundamentally, HIV/AIDS is an infection that is very closely related to human behavior. Unlike tuberculosis or malaria, where tuberculosis obviously is airborne in some respects, but HIV/AIDS, and especially HIV/AIDS, where it is an epidemic, is mostly heterosexual, transmitted sexually, or through drug use. So the policy that it seems like that when we try to address the different aspects of that policy, so we talk about violence against women, or we talk about just PMTC treatments, and not really talking, when you talk of integration, not really talking of an integrated effort from a policy perspective that affects behaviors of the general population, because from a public health, we are really talking about the population level effect. And we also have evidence that shows that the only places where HIV/AIDS rates have come down have been places that have emphasized behavior change, whether it was Uganda or whether it was Thailand, whether it was through legislation or whether it was through this involving the civil society a lot. Then the way that it is being presented right now, you could keep on adding billions and billions of dollars to the Global AIDS Fund, and after 20 years we would still have a large epidemic in the world. We would have surely done more, but we would still have more people who are affected, because the nature of the epidemic in China and Russia and India, and it doesn't seem like a 10 billion or 20 billion infusion or any change that is being advocated right now at the international level will arrest that growth unless there is a fundamental behavior change within that society.
So again, you raised a number of questions. There's no doubt that behavior change is an important part of the solution, and I hope I wasn't suggesting otherwise. Money to the Global Fund actually does go to behavior change. I mean, I was highlighting treatment in my talk, but they fund comprehensive prevention in countries too. So the money and behavior change, I don't think, are mutually exclusive things. What gets more interesting is if you look at the last countries that you described, India, Russia, and China. Now, these are all countries that, to lesser or greater degree, can afford to respond on their own. They're not in the same situation as economically as many of the countries in Africa. So a question I would be asking is, why are India, China, and Russia doing as little as they are to respond to this pandemic? China, under pressure from its own citizens, and they don't respond well to that pressure, as you know. I mean, they recently detained, I think, an 80-year-old leading AIDS doctor, but is moving toward providing treatment. There's a lot of problems in how they're doing that. But that, there was a breakthrough of some kind, and there need to be another breakthrough. Russia, you point out, needles is actually the leading cause there, and they are very resistant. Met not so long ago with a range of Russian doctors, and their government is unwilling to consider the kinds of programs that would keep people from getting infected with needles. In India, it's interesting because India is actually both a place of great success and, I think, of failure. The success relates to TB, which it's interesting that you separate the two because they're actually TB, tuberculosis, and AIDS are, the co-infection rate is enormously high. Latent TB, hundreds of times more likely to become active if you had HIV. TB, actually, people are getting because of behavior. The behavior is that they're going into AIDS clinics. In southern Africa right now, XDR, extremely drug-resistant TB, people are getting because they're going into an unventilated AIDS clinic. And then people are dying. Even if they're on these ARVs, the life-saving AIDS therapy, they're dying because this TB is so virulent. So we need to do a lot more on that TB side, and I wish I'd talk more about that today. And then we need to invest in these institutions, and then we need to put pressure on governments. And so to come back to India, India is both a success on TB, where they've actually got community health workers out there, even people at shoe stands, who are dispensing TB medicine, and it's actually working. It's one of the most successful models in terms of going to scale. And yet on the AIDS side, the government is in great denial. The government, while the country is one of the leading manufacturers of generic medicines, they're not necessarily available to their own people. And the government is under pressure from these same pharmaceutical companies, which I mentioned earlier. And they're unfortunately caving to some of those pressures in ways that will limit access to Indian generics for the rest of the world. So there is no question in my mind that it's not just about more money, it's also about leadership. And in these countries, which have a lot of resources, I think it's especially about leadership. Have I worn you all out?
Well, on that note, I'd like to thank David for a great presentation, handling with deftness, an excellent set of questions, and thanks so much for coming to UT.
Thanks a lot. Yeah, appreciate it.